Hello, my name is Nancy Jacobson. I'm Assistant Professor of Emergency Medicine at the Medical College of Wisconsin, where I'm an ED Medical Director and our System Director for Quality, Safety, and Experience. And today, we're going to talk about high-yield interventions to improve patient experience in the emergency department setting. When we consider improving patient experience, especially in the ED, it's important to remember that it's less about our intent and more about our patient's perception of our care. Our goal is to create a bond quickly. We want our patients to think we're smart and competent, to know that we care, to trust us, and ultimately to be compliant with their medical treatment plan, because this improves patient-centered outcomes. How do we do this? It's certainly challenging in the clinical practice environment of the ER, where we often meet our patients for the first time during an encounter, where people might be having one of their worst days. They might be undergoing an incredible amount of stress or be in pain, and time is not on our side. Nonetheless, there are a few proven techniques that can improve patient experience for the emergency department patient. One of the most commonly utilized communication structures to improve patient experience in the ED is called AIDIT. This stands for Acknowledge, Introduce, Duration, Explain, and Thank. The A stands for Acknowledge. Acknowledge the patient, their family, and any visitors they may have brought with them. Use a greeting and a smile. Make eye contact. I is for Introduce. Introduce yourself, including your title. This is also your opportunity to manage up. Point out the excellent skills of the nurse who may also be caring for the patient, or the expertise of a consultant. This is also your opportunity to engage in service recovery if needed. And we will discuss service recovery in more detail on an upcoming slide. D stands for duration. Explain how long an evaluation or diagnostic workup will take. Make a plan for pain, including redosing if necessary. Tell the patient and their visitors and family when you will be back. Try to avoid saying, "I'll be right back," because this sets you up for failure. Instead, use specific time intervals wherein you set yourself up for success. Underpromise and overdeliver. Also, estimate the total time for the visit so that the patient and their family can plan their day. This is also your opportunity for patients for whom you think there is a high likelihood that you will recommend admission to the hospital to let them know that early in their ED length of stay. E stands for Explain. Explain the plan of care, testing, results, and what you actually think is going on. Find out what the patient is worried about and make sure you address that now. T stands for Thank. Say thank you and close your encounter. Try to find something that doesn't sound false or scripted. One key driver for overall patient experience in the emergency department is the patient's perception of the amount of time their physician spent with them. In a 2007 study in the Annals of Emergency Medicine, patients overestimated the amount of time their physician spent with them by 15% when their EM physician sat during the patient encounter. Meanwhile, when the EM physician stood during the patient encounter, patients underestimated the amount of time their physician spent with them by 7%. Meanwhile, physicians overestimated the amount of time spent with the patient by 6% when they sat during the patient encounter. In a different study, the effect of sitting as opposed to standing on the perception of provider time at bedside was examined in the surgical post-op clinic visit. In this study, patients disproportionately overestimated the amount of time their provider spent with them when that provider sat during the patient encounter. We can see that when a provider sat at bedside, the actual time they spent was 1 minute and 4 seconds. Nonetheless, the perceived time by the patient was 5 minutes and 14 seconds. Meanwhile, when the provider stood, they actually spent more time in the room, 1 minute and 28 seconds. Yet, patients estimated that the amount of time their provider stayed in the room was less than when they sat, at 3 minutes and 44 seconds. Additionally, qualitative feedback in the form of patients' comments were more frequently positive when a provider sat during a patient encounter. Specifically, positive patient comments were present 95% of the time when their provider sat at bedside. When the provider stood for the duration of the patient encounter, positive comments were present only 61% of the time. In addition to sitting, patient experience experts recommend scripting short phrases to highlight for the patients the things you are doing for their safety and comfort. For example, when you enter a patient room and wash your hands with soap and water or with the hand sanitizer, you might say, "Let me wash my hands for your safety." In doing so, not only are you calling out the best practices for hand hygiene that you're performing when entering the room, but also that you're doing so out of care and concern for their safety. As physicians, we are leaders in the clinical space, where communication with the care team and the patient is essential to a positive patient experience. It is important to demonstrate empathy and compassion, not only with direct communication with the patient and with their family, but also with our care teams, including nurses, technicians, consultants, and others. One challenge to patient experience in the emergency department is when we are pulled away to another emergent task, which limits direct communication between the physician and the patient in a timely manner. Nonetheless, with robust communication with the care team, nurses and other care team members can help keep our patients updated and informed on results and on any delays in their ED care. We will examine more closely how important updating the patient is and continuous communication on a later slide. Operational factors in the emergency department impact patient experience. This holds true both with the likelihood to recommend score and for physician overall scores. For likelihood to recommend scores, ED flow-based measures are impactful. For example, total ED length of stay and boarding negatively impact likelihood to recommend for ED patients. Meanwhile, factors such as use of hallway spaces and base clinical hours greater than 1,500 are associated with both lower likelihood to recommend and lower overall physician score. This visual demonstrates the ways in which patient satisfaction is clearly impacted by time spent in the emergency department. However, on the next slide, we'll see how communication with patients is even more important. This 2007 study examines patient satisfaction by time spent in the ED and information received about delays. It represents the experience of 1.5 million patients treated at 1,656 EDs nationwide. While previous research and information shared in this lecture demonstrates that patient experience erodes with longer ED length of stays, this data suggests that if patients are kept well informed about delays, their positive patient experience is maintained. We can see that regardless of whether patients spent less than 1 hour or more than 4 hours, their overall rating of care was much better if they responded very good to the question, how well were you kept informed about delays? For example, if they responded very good to how well they were kept informed about delays, their overall patient experience score is maintained between 96.6 and 97.4. Meanwhile, if they responded very poor to the question, how well were you kept informed about delays, Regardless of how long they spent in the ED, their overall satisfaction score was much lower, ranging between 42.7 and 48.3. One way to employ AIDIT and to keep patients well informed about what they're waiting for and any delays is to utilize a whiteboard. Here's one example. We can see that there are places to indicate who the patient's nurse, attending, resident, or advanced practice practitioner are. We can see also that there are clear boxes to indicate what the patient is waiting for and estimated time to results, as well as tools for pain rounding and a place to write down any questions so that the patient or provider doesn't forget. In the emergency department, we are often in the role of service recovery. There are multiple acronyms and published communication tools that can help facilitate service recovery. One of those is the acronym LAST. This stands for Listen, Apologize, Solve, and Thank. First, listen to the patient. Allow them to explain what they're feeling without interrupting. Next, apologize. Validate their feelings and say you're sorry. The third step is solve. For example, if the patient is frustrated by a prolonged wait time and being in pain, perhaps updating the patient on the reason for any delays and what they're waiting for, and offering pain medications may help. Lastly, thank. Thank the patient for their patience and their understanding. Thank them for allowing you to help them in the emergency department. Here are references for the studies that were mentioned in this presentation. And thank you for your time while we discuss high-yield interventions to improve patient experience in the ED.